Not long after Alexander Fleming first discovered penicillin, he was dismayed to discover bugs penicillin could no longer kill. In the decades that followed, scientists discovered new antibiotics, only to watch those drugs start to fail a year or 10 later as bugs resistant to those new drugs evolved. The question I want to discuss here is what we can do to slow down or stop this evolution. How can we keep our drugs working as long as possible? Attempting to do this is an exercise in evolutionary management. The most successful example of this is the treatment of HIV. When the first antiviral drugs were used to treat AIDS patients, they would work only briefly. HIV has a high mutation rate, so drug-resistant mutants would rapidly appear, and because antiviral drugs so effectively kill off sensitive viruses, resistant viruses rapidly dominated, so the drugs would no longer work and the patient would die. But over the years, several antiviral drugs were developed, and it was discovered that if these were used together, resistance would not arise and the drug cocktail would work forever. That's because the probability of any particular virus particle mutating to resistance against any drug is tiny. The probability that we'll simultaneously get a mutation conferring resistance to 2 drugs is tiny squared, to 3 drugs, tiny cubed, and so on. And so rapidly, the probability that multi-drug resistant virus particles will spontaneously appear becomes so small that it is essentially zero. So a cocktail of drugs stops evolution dead. That is why HIV is no longer a death sentence, at least for patients who can afford the drugs. It is one of the most successful exercises in evolutionary management humanity has ever achieved. For once, medicine triumphed over evolution. It may not be possible to repeat that triumph for every infectious disease, but I don't know of any case where it is not possible to apply the principles of evolutionary biology to at least make our drugs work for longer. Think of it like this. This is a sketch of a resistance mutation spreading in a population of pathogens, from the point where there is no resistance until the point where all the bugs in the population are resistant. Now this curve could be among the bugs in your body, or it could be among all the bugs in a hospital, or all the bugs in a country. It doesn't really matter. The principles are the same. We consider the drug to have failed when resistance has reached some point, and so our aim is to move the curve as far to the right as we can to make the useful life of the drug as long as possible. 2 things determine the shape of this evolutionary curve. First, the time it takes for a drug-resistant bug to appear in the first place. There are a variety of ways that can happen. For example, it can be by mutation, or when bugs get resistance genes from other bugs, or when people catch resistant bugs from other people. But obviously, unless genes are present, there can be no evolution. And then once the resistance is present, natural selection is something to chew on, so the resistant bugs can take off as the drugs kill out the sensitive competitors. That's natural selection. The rate of rise of the resistance is then determined by how strong that natural selection is. If no drugs are ever used, the resistance won't go anywhere. If the drug use is widespread, so that, say, resistant bugs leave 60% more offspring than do sensitive bugs, resistance will spread very, very rapidly, and so the drug will quickly become useless. On the other hand, let's say resistant bugs leave only 5% more offspring than sensitive bugs. Then the rise is much, much slower, and the drug will work for much longer. So the speed of the evolutionary process has 2 main determinants: the time for resistance to arise in the first place, and then how strong the selection is on that resistance when it has arisen. This means we have 2 options if we want to slow evolution down. We can alter the rate at which resistance enters the system, and we can control the natural selection. The good news is that both of these processes, the origin and the spread, are strongly affected by medical practice. That means they are something we can greatly control by how we use our drugs. For instance, as I said earlier, the evolutionary war with HIV has been won because cocktails of drugs with different ways of killing the virus stop resistance arising in the first place. Of course, there are a lot of people with HIV in the world getting these drugs. Could a multi-drug resistant virus arise in one of billions of viruses in those millions of people? Maybe, eventually. At that point, we have to hope that new drugs will be available to add to the combination, or some changes in the way the drugs are combined can be found that will work. A global pandemic of multi-drug resistant HIV would be a disaster. The other option for managing resistance evolution is to try to slow the spread of resistance once it has arisen. There are some very obvious ways of doing this. First off, we can easily stop resistant bugs starting new infections. Today, great efforts are made in hospitals to stop transmission, everything from basics like hand washing to very high-tech ways of sterilizing a room after an infected patient has left. Hygiene is not very glamorous, but it can be highly effective at stopping drug failure in hospitals, where some of the world's biggest problems abound. Another way of slowing the spread of resistance is to restrict the ultimate driver of this evolution, the drugs themselves. Every time bugs see drugs, the strength of natural selection for resistance is increased. Remember the difference in the rate of spread for a 5% advantage and a 60% advantage? One of the major determinants of that difference is how many people take drugs. So we need to hold back our drugs for only the important cases. This is why you cannot buy antibiotics over the counter in rich countries. You need a doctor's prescription. That is an attempt to make sure you take the drugs only when you really need them. There is no point using drugs that work against bacteria when you in fact have a virus infection. Those sort of government-imposed restrictions are, I believe, the largest deliberate attempt to alter the evolution of any organisms on the planet. The same philosophy is used in hospitals, where even doctors often need permission to use certain drugs or for a long time. And it is the reason so many people want to ban antibiotics in animal feed. Only use drugs when there is clinical need. But if you are going to treat a patient, how should you do it in a way which contributes as little as possible to the evolution of drug resistance? This turns out to be a hard problem, and it is a very controversial area of ongoing research in my lab and many others. Let me give you a flavour of the issues. Let's first start by asking what we are aiming to do when we treat a patient with drugs. Well, clearly we want to make the patient as healthy as possible as fast as possible. We also don't want that patient infecting other people, and I would argue we do not want that patient infecting other people with drug-resistant bugs. So that's three separate aims, and they're not actually compatible. If we don't use drugs at all, drug resistance won't spread, but that won't make the patient healthy. So the question is this: how can we use drugs to make patients healthy in a way that minimally spreads disease, especially resistant bugs? Well, there are a large number of options. Should we use a high dose once a day for 3 days, a low dose once every second day for 10 days? Which is best? A lot of the time, physicians don't care about the evolutionary consequences of what they are doing. They use a regimen which they think will make the patient as healthy as possible, as fast as possible, because that is their sole aim. They usually do not worry about the next patient in the transmission chain. If they do think about evolution, a common philosophy is to use a lot of drug, ideally to hit hard and early. And if you can't hit early, certainly hit hard. The idea here is to kill as many bugs as possible, as fast as possible, so that there are few alive to develop resistance. Dead bugs can't mutate. And that's obviously true. But by hitting hard, you're also giving maximum advantage to any bugs that are resistant. You very effectively clear their world of sensitive competitor bugs so that resistant bugs can explode. Less aggressive use of drugs will weaken that selection. It could take a 60% advantage and turn it into a 5% advantage. So aggressive use of drugs to treating infection generates two opposing evolutionary forces. It reduces the resistance inputs into the system, but it gives maximum advantage to any that are present. I don't think it's possible to say how those two opposing forces will play out in hospitals and communities where drug use is rife. I doubt very much there will be any general rules. It will depend on the bug and the drug and a whole host of other factors. It is the job of science to work out what the general principles are and then apply them to different diseases. That science is in its infancy. As drug resistance becomes more and more of a problem, expect this science to flourish. What does this mean for you, the patient? Well, my suggestion is that you follow your physician's advice about how to take your drugs. But expect that advice to change over the coming years as we begin to better understand how medical practice can be used to manage the evolutionary dynamics of drug resistance. The simple stuff is in place now. Now we have to figure out the hard stuff.